We're ready to go. I see noise under there. Okay. So I sent out, you should have all received the syllabus electronically. They asked us, well, I edited it one time because vis-a-vis COVID, and I'm the last person to worry about this type of stuff, but the policy is sort of changing. So one of the deans basically includes this in your syllabus. You may still, if you're here or on any other campus you go to, have somebody who says, "Hey, I want you to wear a mask." I mean, I don't know I'll never ask you to do that. Okay, that's there. There's not that many of us. If you feel like you need to be distance from somebody, be distance. Heck, if you want to wear a mask, go ahead. I'm here. I'm not crazy about that. Everything kind of changed because Allegheny Health Network, and UPMC dropped their mask policy. My wife's mom, who's going to be 97, is in a nursing home. Unfortunately, just got in there from the hospital. And as of yesterday, or Monday rather, the mask policy went, you had to wear a mask to go in there before. So they're finally getting a handle on all this stuff. That's the first thing. So I sent you the syllabus, and today's just me listening to me talk. Okay, so I've got to set up the basics for you. Try to get as much information in because we won't have to be here next week. On the Wednesday of the following week, whatever that date turns out to be, the 17th, 2 weeks from today, we're going to finally get our hands on all of these bones and bone models, plastic bones, and it's kind of important to be here for that. We need to do that. And so when we're you doing hands-on stuff with bones, probably weeks 3 and 4 and 5, which is the bones practical, 3 and 5 are essential to be here. On week 7, undoubtedly, we'll do a dissection of brain dissection. We use a sheep's brain. That's about the only hands-on type of stuff that we need to do. And if you go on and take the second half, there's a couple more dissections that are there where we start getting into the eye, the heart, the lung, that type of thing. Just a little bit. That's kind of the way we work it here. I I don't know if I can get it organized. I might put in a sort of a mock lab on diffusion, but we'll see if I have all the stuff and we can get it together in time. So that's the introductory stuff. There's not a lot, and I'll come over here and take a quick look. Grade wise, I think there's 4 grade things. There are two exams. Effectively, the bones practicals are midterms worth 30 points. It involves effectively the practicals more or less name the bone. There'll be a couple of features that are on it, or maybe some questions about it. All of that I will have to set up, and I'll set it up before prior to you arriving, and we'll get that out of the way the first thing we do in the lab, and then we'll continue on from there. I'll give you all the parameters that are involved with that. Yes, you'll have a word bank and all that type of stuff, and it's not nearly as rigorous as the one that I do in the fall with my advanced, which are the pre-med students and biology majors. We get a lot more intricate with regard to that kind of a test. So that's worth 30. So we figure out 100 point. That's 30. Then we have 30 points that are a similar vehicle for the final. The final is kind of a mixture of a traditional written exam, objective in nature, means multiple choice, true, false, that type of stuff. And again, labeling a certain number of structures, which will probably be muscles and nerves, or parts of the brain, really more than anything else. Because the last part, the nugget that we do here in AP1 is the central nervous system. We do the other systems, peripheral nervous system, heart, lungs, respiratory, cardiovascular, etc. in AP2. If you're around for that. Yeah, come on in. We're just starting it. It's going to be recorded and distributed too if you missed anything. And then lastly, there'll be a couple of quizzes. I'm making them take home. Okay, so you'll get them. They're probably going to be I would say I don't know. I think they're either 10 points, and then there's a couple of other little items. If we're doing a brain dissection, there'll be a report. That'll be part of it. And I say this all, you have to make an effort not to get a good grade in this lab. You have to really put some time into it, which means don't show up, don't do anything, don't turn anything in. Don't do that. It's a 1 credit course. All right. That's the way I work. So that's the introductory material without me having to open the syllabus, which is boring, having done that a zillion times. So I have downloaded a variety of these things, or I will continue to. I have one that's here, and I usually jump to, we'll do this at least today as well. Moving on. So I work under the assumption that you don't necessarily have a background in this, though you may have gotten some of this information. Most of the cellular stuff, if you're taking the companion or have taken the companion anatomy and physiology course from a lecture, they really cover more of the cell. I'll have a very relatively brief presentation, parts of the cell and the cell structure itself, and move on from that, because I usually leave that to the lecture. The labs around here in anatomy and physiology are just that. Most of the physiology and it's pretty much handled in the lecture. This is mostly anatomy. So it's basically, in most schools, and I've taught a bunch of them over the years, anatomy in AP1 is bones, muscles, and nerves. And that's really what we're going to cover. Bones, muscles, and for us, it's parts of the brain as opposed to the entirety of the nervous system. If you got to step out and you need to take a phone call or take I don't care. I'm good with that. The reality is I can usually talk for endless amounts of hours. That's what they pay me to do here. And even occasionally I'll get up. But moving on. So what you will see if you were to look at this, and I don't believe I downloaded that particular one, though I could, just as a brief introduction. Did I do it? It's here. And your Blackboard's open, and all these PowerPoints are on there. We're doing 1B, 4A, and 4B. Just to show you this one. This is the one you typically, so it gives you some context to start with without me going into chapter and verse. So all this will be rapidly appearing. Anatomy literally means to cut up. Okay, that's what it is. The only anatomy and physiology language / medical terminology is very much of a language in and of itself. So there's a lot of suffixes and prefixes. So the only suffix that means to cut. When you make a cut in a bone, okay, it's called an osteotomy. Osteo, as you'll learn, is the prefix for bone. Otomy means to cut. So if you had a broken bone, they had to fix it. Okay, you probably had to make a cut in the bone. For instance, so ectomy means to remove a section of bone. So there's different. That's why you get the term appendectomy. The ectomy means you're removing the appendix. So a lot of it's about the terminology. Once you get that down, and I'm pretty good about explaining that to people, what it is. So in a global sense, it's structure of body parts and their relationship. So that's what the anatomy is, identifying the structures, and moreover, the important features of the structures. Because it's not all as you're going to see down the road, and we spend a lot of time with bones and joints, which is probably the area I know the most about, having operated on bones and joints a very long time. Okay. Physiology, theology means study of, physio means function. So that's really what it is, and they're mated together. There's no question about it. If we look at the structure, we can figure out the function, just see that are there. So what we do is gross anatomy in here. We're going to spend some time on the microscopic part. I'm not going to go crazy and look at the microscope. Maybe I'll set it up for a couple of slides. It's easier for me to project them so everybody can see them. It has always bothered me at this level where they have tests where the professor sets up a microscope and the students who are just learning about this stuff, entry-level students, have to go look and tell them what that is. I didn't do that till medical school. For some reason, I see this in community. For years, I taught in community colleges, so it drove me crazy. It's like, every so often I would say something and I get looks like, because I don't think students are really ready for that. I can give them an idea what it looks like, and it's pretty easy to figure out what it is, and I think that's helpful. So What we do here is what's called systemic anatomy. We do it a system at a time. So we start with today as building blocks: basic anatomy, basic terminology, basic compartments, and a little bit on the magic of something called tissues. Tissues are collections of cells that kind of do the same thing. How they're arranged is really tells you how they work. Okay? And what we look a little bit here is surface anatomy. So we'll talk about all those things. If you're like me, I don't know, but I'm a sports nut. I have a lot of experience with sports medicine, things like that. So if you were watching soccer fans, so if you were watching during, I think that was during I'm a Man United fan, during the European Cup, you might remember that what they call the UEFA Cup now, that they took off Lissandro Martinez. Am I ringing a bell here? Non-contact injury, he did this. Okay, sharp, we call plantar flexion, and I guess his toe got stuck. And it's like, and his teammates from Argentina, which was novel, carried him off, playing for the other team. They were playing for Seville, and I didn't know what it was. The doctor who helps you, Dr. Buxton, is a Liverpool fan, so we go back and forth. But it was the first time either of us had seen that in the years of watching soccer. So what had happened, it's a classic fracture that we'll talk about, and it's about looking at surface anatomy. You could tell right away what it was. There's a bump on the outside of your foot. It's called the tuberosity, which is a name for a big bump, of the fifth metatarsal, which is the big bone behind your little toe. And a tendon is there, and it lopped off, it pulled off that triangle bone. And I'll have to screw that back on. Those are the kinds of things, if you're pursuing a career in sport or medicine or training or whatever you're going to go into, for a lot of the people who take this course, that's the kind of stuff that's relevant. So I always have a good time with those kinds of things that are there. And so we'll show you a little bit of the microscopic anatomy because it gives you a much better idea of what's going on in the cell. I don't do a lot with developmental anatomy comparatively. I do that in the lecture components when I do anatomy and physiology. And so that's kind of what's going on. So we're not spending a whole lot of time with this. And so we'll look at the different systems that are there. Again, I usually don't do this part. The physiology is much more intricate. But this is the big player here: complementary structure and function, the relationship between the two. Here's bone, layers and layers of organic material that's packed with calcium salts, giving it rigidity. Yet, because of the way it's constructed, there's a certain degree of flexibility. You know that that's going to be a supportive structure. That's the idea. You can see it the way muscles are layered, and we'll look at some of that in the way that it works. So they're just showing you some of this, like different teeth, different shape. What they do is their type of thing. And so what I do in lectures, we talk about this different levels. And but fortunately for you, we don't have to worry about this. We're going to look at generically at cells. We'll look at the groupings of similar cells, tissues. That's important. Because when you put two or more tissues together, you have what we call an organ. Take a relatively simple organ like the liver, extraordinarily important. The cells are almost identical, and it's really got a boundary of a different kind of tissue on the outside. It kind of holds together. Yet we die without it. We die if the function is impaired with that easily and relatively quickly. And if we have a whole bunch of organs that work together, we have an organ system. Liver's part of the digestive system. That's an AP2 thing. And then we have, combine all those systems, you have us, an organism, a living thing. And they're just showing you these. They're showing you the vascular system here. So anatomy and physiology, you start, and these days we understand it more because understanding how it works is on a molecular level. Way back when I was even to the point where I was in medical school, we didn't have a whole foundation about how things worked molecularly. We knew the chemicals, surely knew about DNA, but we didn't know all the intricacies about it that were there. That was at the early days of molecular biology. I mean, every time I say this hurts. I started in that school 50 years ago. Thanks. Everybody, you all kind of shook your heads and go, that's not possible. So it doesn't. My youngest is 37, so I already know that. I have a 21-year-old granddaughter. Okay, so here we go. And this is kind of what it does. We're not going to get into all the requirements, but again, it's physiology. And they go, so if you want to scroll through this, PowerPoints are there. And then different parts of the system, but we're going to look at them. But again, that's the physiology. So when we look at this, just to highlight it, what we're going to spend time with are the bones and where they come together, joints. Okay. We'll spend time with muscles, and you identify muscles largely based on their shapes and their locations. And then lastly, this, the brain and the spinal cord, which you and I have a name for, it's called the central nervous system. And that's really what everything else is an AP2 type of thing. Okay, and that is all physiology stuff, the nature of controls and the feedback mechanisms that are involved. So I did want to put that in for introduction, and I'll move on. So this is our part, not A. Wrong one. Where's B? Lost it. Backing up. Gotcha. Now I have to stand up. In science, you have to have standards. So, somebody's a diabetic, and they say their blood sugar is 20, but they wouldn't be alive. 21. So it happens to be your normal blood sugars are roughly between 65 and 110, what's called milligrams percent. Milligrams in the blood have in 100 milliliters or cc's, cubic centimeters of blood. So things are standardized when we do those kinds of things. When you feel good and you take your temperature, you have a temperature of what? I mean, if you say 37, if it was 37 Fahrenheit, you'd be dead. But if it's 37 Celsius, you'd be normal. So we have to have standardization. From that is this, the anatomical. So anytime you ask a question in anatomy, it's based on that position. And so it's more or less relaxed stance. The nuance is this. You'll see a lot of illustrations that aren't accurate. Normally when you and I are relaxed and standing, our feet are spread a little apart because it's more comfortable. Gotta be straight. Our palms are at our side, like this. That's the anatomical position. If you're upright, palms forward, that's interesting. Fancy name for palms being forward is called supinated. Turn around, it's called pronated. It has a lot of different meanings. But normally we keep it at our sides. But we have a certain way of doing that. And the terminology all comes from that position. And inevitably, when we're asking questions about it, it's always usually compare structures. We'll say, what's the relationship between your elbow and your shoulder? So you can't say, well, your elbow is what? Well, it's out there. So there's a certain nuances to that. The default is our standard anatomical. Feet are roughly the width of your shoulders, palms are forward, thumbs are pointing away. And all these terms that we're going to get to, the directional terms, have to be based on that position and typically reference to each other. And be happy I don't do rights and lefts. It's confusing. That's part of the way I probably have done this presentation. I can't tell you. So we're going to look at the terminology and what that position is. It differs for every species. This is for us. This is human anatomy. It's that handsome dog. Dogs are on all fours. Okay, so it doesn't apply. 4 feet, 9 feet that are there. Their snouts in the front. Okay, tails in the back. So we use different kinds of terminologies, and sometimes the terminologies in science overlap. So we have terms that are more associated with humans, but we still default sometimes to terms that are, and particularly when we do the central nervous system. Then we use older terminology because that was probably the first system that was really explored. And so you're going to hear some of those older terms, but we don't get there till the end of the term. Anyway, so voila. So we describe them typically with regard, if it's going to the top, we use the term superior. If it's going toward the bottom, we use the term inferior. So your head's certainly superior to your abdomen, your belly. But your belly's certainly superior to your feet, so your feet would be inferior to that. These are those terms I was telling you about, cranial and caudal. Cranial means head or brain. Caudal means tail. We don't have them. But you're going to hear the term utilized in some of the structures that are there. Front and back. Modern days, we use the term anterior, forward, posterior, back. Theoretically, which you hear a lot, remember the dog on all fours, dorsal is back, ventral is belly. And you're going to see we use those terms a lot, again, in the nervous system. So there's a couple of oddball systems. That's the one that's the most. So you hear a lot about that are there. Again, standing up, the midline is critical. You're going to see why, because these terms come from what are referred to as the body planes. Planes are very relevant. I don't know where you're going with your career, or if you're just taking this because it's something you're interested in, or you want to get science elective in. Doesn't matter to me. You pay me to teach. So you're stuck with me. You can be a little irreverent when you get older. So the midline is here, and so we have terms toward the midline, medial, away from the midline, lateral. We use those terms a lot. And then if you have like three structures, you have something in between that are there. And when we come to naming things like muscles or certain bones, you're going to see the term intermediate. A lot of times, like in your finger, you have three bones. They're called phalanges. The singular is phalanx. And you have proximal, the one's closest to the trunk, distal, the one that's farthest away, and middle or intermediate in between the two. It just depends. And so we do everything with regard to that. And so back to the same terms, when we look at extremities, particularly upper or lower extremities, so the whole shoulder arm assembly to your hand, or the whole hip down to your toes assembly, we look at proximal and distal. Those terms are used a lot. Proximal means closer to the torso, distal means farther away. And when we look at things more so we're composed of a lot of layers. So a lot of times we'll look at structures that are outside and inside, except we don't use those terms. So we use superficial, which means toward the surface, or deep, toward the interior. And so once you get to the middle and you're starting to go about the other side, now you're going back to superficial. So you might have something that's centrally placed in that one. And so those are parts of the terminology. And what this all refers to is this, and I'll jump ahead a little bit. The way it's constructed. So if anybody here has had an MRI or a CT scan, it's all based on this. Years ago, and I can tell you because I was here, I was in practice before we had that technology. Okay. We had x-rays, and all we could do with the x-rays was take a series of them at different angles and try to interpret them. Well, we didn't have the ability to see inside of a knee to see if somebody had ruptured a collateral ligament. We had to inject it with dye and see where the dye went and didn't go to be able to tell. It's called an arthrogram. We didn't have the luxury of being able to relatively quickly do an MRI. So what they'll say, I'll have a scan. The computer age changed that. So if you have had a CT scan or an MRI scan, that is based on effectively a computer algorithm that has taken multiple pictures. Okay, the computerized tomography, when we used to take those angle pictures, was called a tomogram. Now we've computerized that, and depending on where the device is taking those images, in what we call advanced imaging these days, we're able to complete a computer picture that basically lets you see the whole thing. And particularly what's neat is you can do them. I mean, maybe you've seen one, like you go to a doctor's office, they can move it back and forth along where the pictures are and actually take a whole, almost look like it's moving. In the MRI, they're doing the same thing, but they're not using radio, they're not using energy, they're not using ionizing radiation, which is potentially dangerous. We're using magnetic current. That's what stands for magnetic resonance imaging. When you apply magnetic fields to molecules, and that's all we're made of. We're made of organic chemicals. We have lots of hydrogens. And those hydrogens, effectively, when they get excited, if they can get loose, are called protons. But that's what MRI. You don't have to know any of this stuff. I'm not doing a course in physics, anything along those lines. But effectively, what happens is we excite, the magnetic current passes, excites them. When they get excited and drop down, they release energy, and we create an algorithm. I was doing MRIs back in 1971. That had nothing at all. That was how we analyzed substances in organic chemistry. I was a chemistry major. To give you an idea. But you're going to see it. Why am I giving this long speech about this? Is because that's what these planes are. So when you look at a knee, you had your knee MRI or CT, or your arm or anything like that, they take, we call them slices. Effectively, the computer is able, from that technology, to look at these different slices. We used to put them up and look at a stretch of films where they were. Now they can do it all digitally, and again, make the movements fascinating. So you have 3 different planes, and the plane is nothing more than something to demonstrate with. Boom. So a plane. So a plane that goes down your midline like this, a vertical plane that's going this way, is dividing you effectively into right or left. That's called the sagittal. Vertical plane going side to side through you this way is called the frontal or coronal. Coronal now we understand because it means corona was it's like a glow, like a star, like a halo. That's what the virus got named for that. But the term's been around for a long time. So another term is a frontal plane, divides you into effectively front and back. And then classically in anatomy, for years before we really did a lot of other stuff, we had transverse or horizontal planes. You had a plane that was this way, typically roughly through the umbilicus, belly button. We called them cross sections. And traditional anatomy, they did a lot of that. We were in advanced classes in professional schools. Something, if you're going where you're going, where you'll put a slice in here and tell me where it is. They'll show you all the structures. What are the names of the muscles? What's the name of the bone? The bones, nerves, blood vessels. Fine. So we call them sections. So we look at sagittal sections and coronal, and I'll get back to it. But and I'm only concerned with the ones in the middle. Front and back exactly in half, front and back, right and left, this way. So I don't want to show you. And you can see they describe these. And again, here's the cross. I'm not dealing with obliques, but it looks like this. So here's this person. More or less, her hands are too far away to truly be in the anatomical position. Sagittal plane, frontal plane, a transverse plane. So everything but her hands are too far away from body. But look at the films. These are enhanced images, some way, shape, or form. I'm with people. I should have put. I'm sorry, I didn't mean to. Hold on, I'll do this. I don't know how to do it, but I did. So here you can look at this. This is almost as though, like if you had a chest X-ray. This is kind of what they would look at in the old days without all the advanced imaging techniques. So that would be this kind of a view. This, if you're looking at the side, you can make out the spinal cord and see maybe some of the abdominal pelvic structures. And the same ones over here. You're kind of like midline. You can see the vertebrae, and maybe you can see some of the aorta, the pancreas, sort of in the blood vessel, etc. Things like that. And so it's quite a science and quite an art to be able to learn to do this. And I'll backtrack. So that's really the relevance of this terminology, but they are very important. And there's a few questions that are phrased like that, like the elbow to the fingers, the elbow to the wrist. The elbow is proximal to the wrist. The thumb in the anatomical position is lateral. It's outside of the pinky. Even though normally we think of the thumb being toward the middle, it's not quite the same. And it's different in your feet. Because your feet, your big toes, are closer to the midline. They're medial, and your little toe is lateral. So it's a little bit different because we have our palms out in that regard. And this is important. The best way to remember this stuff for tests or whatever you're doing going forward is, okay, we put things, everything is about in understanding science and learning, and the way your mind works is to compartmentalize things to memorize. You can sit there and look at a picture of a bone and say femur, 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 femur. What we call rote memorization. It doesn't work there. When you put it into packages, and that's what they do anatomically. First, we talk about structures that are associated with the trunk. They're called axial because we rotate on our axis. Anything that has to do with our appendages, we call appendicular. So you have the axial skeleton, head, neck, vertebrae. Everything else is appendicular, including the connectors. Your shoulder assembly and your hip assembly, by definition, is part of the appendicular skeleton or the appendicular portion of the body. Most books refer to it this way. And then we look at the regional terms. So you'll see when we start to study bones, we're going to first look at the axial, hardest part, the skull. And there's only 22 bones. 8 called cranial, surround your brain. The other 14 are facial. They make up your face. So when you remember things, it's easier to do it that way. And I've been doing it for a while, so I give you some tips on how to do this. Appendicular, different. Okay, again, it's not just the extremities, the arms and legs and fingers and feet, toes, etc. It is the connectors, so the shoulder and the hip, which are similar but different in regard to how they're structured. But what you will have to be a little more familiar with are these regional terms. So, and the beauty of anatomy is one term gives you a lot of bonus points for that. Meaning frontal. Frontal means your forehead. There's also, so it's the frontal area, sitting in front. There's a frontal bone. There's a muscle that sits on top of it, one on the right, one on the left. And all we have to do is add the suffix is, called the frontalis. And what's it covering that bone? It's covering the frontal lobe of your brain. You get a lot of benefit out of one name. The same thing for the back of your head. It's called the occipital area. It's got an occipital bone. That's right, an occipitalis muscle. That's right, an occipital lobe of the brain. When we get to the side, we have something called the temporal area. So if you're wearing glasses, these little things are called, our friends who make the glasses, those are called the temples. Okay? This is the temporal area. Same thing, temporalis muscle, temporal lobe, temporal bone. So a lot of the structures give you bonus for that. There's no orbital bone. In sport, you're constantly hearing about somebody, oh, he fractured an orbital bone. There is no orbital bone. The orbit is comprised of 7 bones. There's an orbital area, and you don't want to break anything there, but if you get struck in that area, whether it's by a hockey puck or by a soccer ball coming in and you get misheaded or strikes you in the face because somebody kicked it, but end up with that. So the orbit is designating the area. So you have an orbital area, the opening for your mouth, oral. So it's an oral opening or an oral region or area. Nasal having to do with your nose. There's also, as you will see, a nasal bone. Buccal. So there's a very good dish that's made by slow cooking. I cook called ossobuco. So it's got a lot of wonderful mouthfeel. That's where the buco comes from. Also for the bone. What they do is they slow cook, typically like very, very tough leg bones. That it's a way of using a non-tender area. So instant pot, pressure cooker. So buccal means cheek. There's a muscle in there called the buccinator. It's how you purse your lips or whistle, holding them together. It helps you. It's not a muscle for chewing, but it helps you chew. Mental. Some of these make no sense. Mental. Oh, that person's mental. Well, we may have an expression colloquially about someone who's a little, trying to think of it, mentally disabled or incompetent. But mental means the chin. The point of your chin is the mental protuberance. Okay, where'd that come from? Cervical means neck, but the cervical area for us is the neck. Sometimes we will, in anatomy, though you won't have to worry about it in this class, there's something called the uterine cervix, which is part of the female reproductive system. It's the link between the vagina and the uterus. The neck area is there. It's a very important area because unfortunately, a lot of cancers develop. The chest area is really the thoracic area, and cervical, thoracic, and as you get lower down in your low back, something called lumbar, and eventually coccygeal, sacral and then coccygeal are the names of the vertebral areas. So when we study the vertebrae, that's part of it. But what we see here, okay, is you have the thoracic area is referring to the general area of your chest that are there. The mid portion overlying the breastbone, which is the sternum. The axillary portion, underarms. The maxillary portion is the breast area. Okay. Okay. So a bigger part, the mammary area, not maxillary or maxillary something. The mammary area implies breast. They sit on top of another name that you'll see associated with called the pectoral area, pectoralis major. Now that people work out and go to the gym more, we tend to see they're much more familiar with muscle names because what am I going to work? I'm going to work on my pecs, or I'm going to work on my lats. I'm going to work on my traps. So it's short for trapezoid or latissimus dorsi or things like that. Yes, I have been to a gym. I know. So I never was to one until I was 55 years old. I'll be 72 next week. So I. Took a while before I became acquainted with it. My wife insisted. So she would often look at me and say, "You're getting your corpulent posterior to the gym," which is, and as a wife would tell a husband, "Getting your fat ass to the gym." And I knew just how to talk to her. I know what to say when she talks to me like that. Yes, dear. See, I got it. I'm good like that. I know exactly what to say. I've stayed alive so long. The abdominal area, belly area, umbilical, belly button that are there. And then if we look just a little bit in the upper extremity, originally they called it the brachial area. When you take blood pressure, with a blood pressure cuff, it's the brachial artery to go over in AP2. The point of the shoulder here is called the acromion. We'll see that when we look at bones. So for the area where they draw blood, this is called the antecubital area. Ante, A-N-T-E, means before. The cubital fossa, this indentation, sort of that crook of your elbow, happens to have a name. And there's even a cubital vein. that's in there that we draw blood out of. So if that's the brachus, they used to call this the antebrachus. But now I just say arm and forearm. It works. Okay. A lot of times you'll have a name for the bone. There's one bone here, it's called the humerus. In the forearm, you have, on the thumb side, you have the radius. On the pinky side, you have what's called the ulna. So sometimes referred to those names there. And they'll do the same in the leg, where you have tibia and fibula. When you get to the wrist, it's called the carpal area. When you get to the palm, it's beyond the carpal area. The carpal area is here. Beyond the carpal area is the meta. Meta means beyond carpal area. And then you have the phalanges, which are the fingers. Digital area that's there. And you'll see the same, and with extremities here, it's useful because hands and feet have very, very similar names and very similar numbers. Thigh area is frequently referred to by the largest bone that you have, the longest and strongest bone, the femur. So you can call it the thigh or femoral area. We use the term coxal for hip. You can just say hip as far as I'm concerned. Kneecap is the patella. Behind the knee, you reach back there. It's a very interesting, busy area, highly trafficked, a lot of structures. Those little indented areas under your arm, the axilla, the cubital fossa, and the popliteal fossa are busy. A lot of vital structures go there. You don't want to get hurt there. So when we get to the leg, I just say leg. In the old days, they say crural, and they use calf with sural, which would be, but you don't see those terms as much now. And now we basically look at the tibial area, the large bone on the medial aspect going down on the interior, on the big toe side, and the fibula on the lesser toe side or the little toe side. So we usually use those terms. In the old days, they used the term peroneal, which is confusing because the area in the groin where it's sort of like in the under area is called the perineal, an I rather than O. It's a lot of that change. And when you get to the ankle, you have tarsal, okay? You have two large bones, the calcaneus, which is the heel bone that you weight bear on. And you have another area, a bone that's right under there we'll look at called the talus, which is really the whole extremity sits on. That's a very intricate joint. If you're a fan of golf like I am, Tiger Woods just had to have that area fused. Damage. That's an enormously big procedure, and what's called a subtalar fusion. Okay. And then beyond that, you have metatarsals. Think of that as the bulk of your foot, and then the digits themselves. And so on the back, it's the same thing. Okay. The head area, otic implies ear, occipital, as I told you before, is up there. When we look at the back of the area, the posterior portion of the back, we sometimes will name it for the protrusion here. We'll look at here, you'll feel that in the back. It's called the spine of the scapula. So that's the scapular area, that bony protrusion that's there in the back. There's the lumbar area. It sort of indents. So we call it the small of the back because of the indentation, but the bones are the largest. Then the sacral area, and then the coccygeal is sort of like we call our tailbone. You take a fall and you sit down hard, sometimes you can really hurt that. Nothing dangerous about it, but just hurts. This area is named for the muscle. It's called the gluteus maximus. So the gluteals are that. And again, it's structures that people might work on in the gym to tighten up. The perineal area is between the anal opening, the anus, and the external genitalia. That's, like I said, they changed the name from peroneal down the lower extremity because it was kind of confusing. See the oneal here and the ineal here. And then the rest of these are very much similar. So just the planes we went over and the sectioning of them. Well, I'll grab a little break to save my voice in a little bit when I get through all this, and then we'll start with the second section. Again, we're looking, and now they're showing you that particular plane, and kind of, if you would look at it, and like I said, that's the context to look at it. We have a lot of the students here, we're going into imaging and nuclear medicine. science, and then we have a division here for pre-health careers. It's now part of nursing, where they become more familiar with this. And then lastly, in this first sequence of no, we have to talk about the regions. Now we have cavities. It's not a solid body, okay, by any stretch. So these internal cavities are closed to the environment. So your nasal cavity, your oral cavity are open to the environment. We breathe. We have tons of microorganisms we're encountering constantly with that. These cavities are different because they're inherently sterile cavities. If something from the outside, a foreign particle, bacteria, virus, whatever gets in there, it's big trouble. So different degrees of protection. So you have one cavity that has one purpose called the dorsal body cavity, and one that's very, very much larger called the ventral body cavity. So the dorsal body cavity houses one thing only, the central nervous system. By definition, the brain and the spinal cord. So technically there's a cranial and a vertebral cavity, but that's just because of where they're located. It's a continuous cavity that houses those structures. That's just one job. Anything that's important is going to have some type of protection. So vital structures, the more important they are, the more likely they're going to be surrounded by bone in these cavities, like your brain or your spinal cord. So not only is there a cavity of their own, but they also have their own layer of protection that's there. That's the only thing that's in that dorsal body. Now the ventral cavity is much larger, and it's really one giant cavity that's divided into two, not equal, by an extraordinarily important structure, which is a muscle called the diaphragm. So, unfortunately, almost everybody knows somebody who's had a diagnosis of cancer, or you'll read about that. Somebody will die and they'll say, oh, they were just diagnosed with stage 4B, some kind of a cancer. What does the 4 mean? When you track cancers, one, cancer's in one place. Two, it's spread locally to what are called lymph nodes. Three, it's spread to other organs on the same side of the diaphragm. Four, it crossed the diaphragm. That big, thick muscles are big barriers to things spreading. Infection, cancer. When it goes from one side of the diaphragm to the other, big trouble. That's why the diaphragm is important. So we have two, we'll deal with the top one. Extraordinarily important. It's divided into 3 additional compartments that are also sealed, and one that's a bit more open. Okay. The 2 that are sealed on either side, we'll deal with the one in the middle, the heart. So it's a subcavity called the pericardial cavity. It's around the heart. The pleural cavities, one on either side, are for your lungs. The linings bear the names. When we look at the linings, the pericardium surround the heart, peri for around, cardium for heart. Pleural linings surround the lungs. And then this area between the pleural cavity on the right and on the left, okay, is called the mediastinum, which means mid-sternal area. So the mediastinum houses the pericardial cavity, but above it, you have the superior mediastinum. That's where sort of your throat ends. So it's the area where your trachea, your windpipe effectively, goes into that area along with your esophagus, which is carrying food. Here's the diaphragm. In this big cavity, there really isn't a divide. It's sort of anatomical. If you take the crest, put your hands on your hips, everything below that is pelvic, and everything above it is abdominal. So we give it one name, the abdominal pelvic cavity. And in general, all the abdominal viscera, with the exception, viscera means organs, with the exception of like the bladder and some reproductive structures in the rectum, are down in the pelvic area. If you look When it comes to here, the ribs surround the lungs and the heart, protecting it. The muscles are very, very strong here as well. Even the kidneys are surrounded in the back by some of the ribs. Here you have the large bones of the hip assembly sort of enveloping the reproductive system. It's a recurrent theme. I have a lot of those in anatomy about how we protect things. So thoracic, abdominal, pelvic, pleura around the lung. The mediastinum has the pericardial area, but other stuff in there. Abdominal and pelvic, as you can see, relatively speaking, what we talked about. When things go where they're not supposed to, it's bad. The term hernia is just that. It means some of your abdominal pelvic contents, an organ or a structure in there went where it isn't supposed to. So if there's a weakness in the diaphragm, where the esophagus enters the diaphragm, you'll learn about in AP2, it's called the hiatus. Hiatal hernia is when you get an outpouching of, it's like a bubble in a tire. You get like an outpouching of the bowel that goes up into the esophagus, inevitably heartburn from it. Sometimes there's a lot of names, gastroesophageal reflux disease or GERD, heartburn, agita. Every culture has its own name that are there. And yeah, and it's not just a disease of older folks. Newborns can have that. They're born with that. So when you hear about a sports hernia or a rupture, which is pretty common from lifting or from certain physical activities that are there, that's in the lower portion of the pelvic. And sometimes when you'll have somebody have abdominal surgery, they'll have what's called an incisional hernia to weaken this very, very strong tissue that covers this area called the peritoneum. It's very extraordinarily strong. I unfortunately have had not one but two major abdominal surgeries. The last one was more than 20 years ago, fortunately. And I didn't suffer with one of those. So that's really strong stuff. All of these have linings. The linings, for the most part, are moist because in anatomy, things move over one another. And in order to do that, to resist friction, they need lubrication. And so when we talk about serous versus mucus, mucus, when you sneeze or cough up something, it's very sticky. It's got a lot of protein in it. Serous is like a delicate fluid. It's just like, it's like something you put a little bit of something on your hands. Maybe you have used eye drops. They would be like that. If you had a vehicle and you were putting just a little bit of oil that was very, very light in it, we had to open up a hinge or something like that. So most of these membranes have a lining on the wall of the lung. We refer to that as parietal. And they have a lining on the organ itself. So in the lung, you have parietal pleura and visceral pleura. In the heart, parietal pericardium and visceral pericardium. And the fluid, because it's moving, kind of serves its purpose to lubricate them. And even in the abdominal pelvic area. So they use the analogy, it's like it adheres to the heart, like if you had a balloon and you could put your hand into it and you have the balloon layering around it. The air would kind of be like this fluid, and what's left of the balloon would be against the wall. They use that. I don't know if that holds or not. And they can become inflamed and cause a lot of problems. And in anatomy, depends where I do it this way. I make it easy. Quadrants. It's like you take your umbilicus, you take a bony prominence here called the xiphoid process. It's like if you took CPR, you learn about that because it's a landmark. You draw a line down that way and a line creating four, basically perpendicular to it, and it's quadrants. Here they are. So here's roughly the umbilicus. There's xiphoid process all the way down, almost as if you're going straight down. And you have right upper, mostly liver, gallbladder. When someone has gallbladder disease, we typically have right upper quadrant plane. When they have right lower quadrant plane, we think about appendicitis. And then intestinal problems and stomach problems. So that's in clinical. When you say clinical, it means associated people. So if you went to the hospital and you're having right lower quadrant pain, they'd be looking at you, depending if you had a fever, maybe some other signs, they'd probably look at you and think, maybe we have a case of appendicitis. In anatomy, they use a more intricate way that I don't use so much. They basically create a tic-tac-toe board out of you, with the one in the middle being the umbilicus. So you have the umbilical area, above it, above the stomach, epigastric, below the ribs, chondro is the cartilage of the ribs, right and left hypochondriac. As you can see over here, you have lumbar because it's right about your middle of your low back, right and left lumbar, pubic or hypogastric because it's in the pubic area, and then right inguinal and left inguinal. I don't use them so much. Stay away from them. So it's all about, and then these other ones, these are open, oral to a certain, nasal, orbital, open. Middle ear is closed for the most part, but stuff can get in there from your mouth and your throat. So they're open cavities that have contact with the environment. Joints do not. We will learn about joints in this. I have a lot of information to share with you about that as well. And so, in interest of my voice and your attention, take a break. I'll see you at 2:00. Maybe we can do another hour and be done with it. That works for you. Why am I getting these things? Oh, they called me back. To my mother-in-law at the hospital to the nursing home. It's about the bill. Let's close this out. I'll take a break.